Good evening, good afternoon, all of you. Um, we're going to continue the presentations, and this time about an article presented in Radiology. It's an article from multiple institutions in France. It was published this year, 2020. The title of this article is Combining Volumetric and Wall Shear Stress Analysis from Computed Tomographies to Assess Risk of Abdominal Aortic Aneurysm Progression. So basically, just as a matter of summarizing this article, which we're going to fly over a bit quickly here, what they're doing is they're trying to challenge the classic concept of just basically looking at the diameter of the abdominal aneurysm uh, itself, the diameter, which is most of the parameter that's been used, or the increase in its diameter over time, um, by using volumetric and functional assessment to have a more specific outcome of the progression, and to be able to treat patients according to this new logarithm. So basically, just introducing here, uh, the abdominal aortic aneurysms are a serious and common pathologic abnormality where you have in men more than 65 years of age a global prevalence of about 7.7%, that increases to 8.9% in more than 74 years old. So what has been related here, as you can see underlined, is that the diameter of the abdominal aorta aneurysm has been correlated to the rupture rates of the same, where the threshold of 50 to 55 millimeter, or a growth more than 10 millimeters per year, has been positively correlated with an increased risk of the rupture. So this model, what they're challenging here in this article, can be insufficient in small aneurysms to predict the rapid growth, and in context of heterogeneous population. You see, where we have a population that's including many individuals with many different factors, we can't always assume that what is true for one person is true for the other. So they're trying to broaden the parameters, and in this way make it more specific. So what they're also mentioning here is that the volumetric analysis, that is including, as it says by its wording, and analyzing the volume characteristics of the aneurysm, rather than just a two-dimensional diameter. What they're trying to do is see if it's really such a promising technique as it seems. Well, that's what they're trying to see. The morphologic changes in many aneurysms are not reflected by the maximal diameter itself. So you can have changes in an aneurysm's size and shape, while this may not be reflected in the diameter itself. So what we're trying here to do is also, to combine this volume analysis with functional analysis of the vascular flow, where we have the computational fluid dynamics. Basically, they include in a very complex computed logarithm the pressure and the shear stress derivative parameters. Just for us to kind of follow that a bit before plunging deeper into the topic, when we speak about shear stress, it's a stress exercised parallel to a surface. So it would be something like basically when you have a force that is working on the endovascular surface, it's working in a parallel sense, and this is the type of force that they're speaking of here. We're going to talk about that in a while. In the meanwhile, just to use a bit of fun and some illustrations, you see a couple of bars there in the illustration on the top left. Basically, what it's trying to illustrate is that two bars that run parallel but in opposite directions will generate friction between each other, depending on course of the material of the surface and so forth. But yeah, that's what shear stress is actually. When we come to the physics of it, then well, you have a sheep, and the etymology of the word shear or shearing actually comes from well, yeah, simply shearing sheep, which would be something that you would do with your hair with simple clippers, but what farmers do when they um, remove the wool of the sheep. So that's just to exemplify. Since basically when you shear a sheep's wool, you're exercising a force parallel to its skin, so to speak. So the purpose of this study is to identify these volumetric and computational fluid dynamics, these parameters, to define new parameters, to identify abdominal aortic aneurysms that are most likely to increase in size. So, just to talk a bit about the materials and methods, this was done in 2 university hospitals in France, and all those who were referred for vascular surgery were included. So, some of those characteristics of the patients that would exclude them from this study was, for example, having an acute aortic disease symptom or an aortic dissection, previous procedures, pregnancy, which is written up here, or if you would have a contraindication to contrast material enhanced CT scans. If the CT imaging study was incomplete, if you had an insufficient image quality, and so forth. Then some of the characteristics, just briefly here, you had 2 examinations, one initial and then one at the 1-year interval. The CT scanners used were either of 2 times 32 or a 64 detector row CT scan. All studies were contrast enhanced, so they used 100 milliliters of iodinated contrast material, scanning from the base of the neck to the ischium. So when they plotted this graphically, we finally see here that we have 81 patients, and we'll talk about the 2 different groups there. So anyway, this table shows a bit of the statistically significant values that basically the cardiovascular risk factors were quite important, but mostly if you've ever smoked, that was significant. Also, the intermittent claudication was, and the maximal diameter, which of course has been the traditional means of measuring the risk of rupture. It still shows to be statistically significant, but here they're comparing it to some other factors. So here you can also see some of the volume and the characteristics that they are comparing. Basically, all of these are statistically significant, the aneurysm volume and the diameter and so forth. We're going to analyze per group, so without having to go deeply into that. Now, before going into a bit of the images, just to mention in the materials and methods that in the statistical analysis, a p-value less than 0.05 usual value was considered to indicate a statistically significant difference. So we had basically 2 groups. Here you can see, the progression group would be represented by the left side images. The progression group are the people that had, advancement of the disease, and then you have the reference group, which is called the validation cohort. Basically, using this image, although it's not the main purpose of this image, but just to explain here so we're following, you have the derivation cohort of 50 people, 50 patients, where you had a probability of progression, and the validation cohort of 31 individuals. These 2 groups were compared just to show if there was a statistically significant difference between both. So the threshold to differentiate the one group from the other was the volume progression of more than 10 milliliters. So if you had more than 10 milliliter increase of the volume, on the other hand, less than 10, you would be classified into stable or progression groups. within these two groups. So you have two groups. One is the progression group, one is the validation group, and then within those two groups, you are classified as a patient who had a stable aneurysm at the 1 year control, or if you had a progressed aneurysm by itself. So then these figures, starting with this one, this is comparing the pattern of the wall shear stress. The shear stress I mentioned is the stress that's exercised parallel to the wall of the aneurysm. So basically, what this shows, which we're going to analyze later, is that where we have an increased stress, and where we have higher value of the stress, this has its effect on the progression, and when we have lower values, this has another effect. I'm going to talk about that a bit later, but just keep this image in mind. These are different shapes. Also, you have the fusiform and the saccular morphologic structures. So just keep in mind here, just so you don't lose that information. Where we have the progression group, left side, you have low shear stress values, whereas in the stable group you have high values, which may seem contradictory, but we're going to talk about that in a bit. So the results of the study shows that these the initial 331 patients included in a prospective registry of infrarenal abdominal aneurysms. They were, well, 205 of them were initially referred to surgical intervention quite immediately, so they were not included. After all of the different factors that I mentioned that led patients to be excluded, we were left with 81 patients finally. So some interesting things to keep in mind was that the mean and maximal diameter was larger in the validation cohort. That's just something interesting to keep in mind. Statistically significant was the intermittent claudication prevalence and the ever smoker status. That was different between the two groups. So now, speaking of each group, keeping in mind this is the group that was compared to the validation group. So the derivation cohort is the group that's being studied to see if there was any change. So you had, within the derivation cohort, you had stable aneurysms in 30 patients and progressed aneurysms in 20 patients. So an interesting, very, very interesting thing to keep in mind, but is that the mean variation of the volume was 21 milliliters in the progression group versus 3 milliliters in the stable group. Within this cohort, 21 versus 3. So there is no difference between the progression and the stable groups for the mean maximal diameter. So this is interesting. The mean maximal diameter stayed the same, but the volume changed. So first tip to keep in mind when we're comparing these two methods. Here we have an interesting table that's basically showing the sensitivity, the specificity. What they did was, I think we mentioned this, that we had a third cohort with a group of aneurysms less than 50 millimeters in diameter. So basically, for this particular third group, which was a group of 52 patients from both the derivation and validation groups, here the AUC for this subgroup is significantly different. So this is where the model was strongest. Let's go down here. So for the validation cohort here, we had 31 patients that were divided in 14 patients who were having a stable aneurysms at the 1 year control, and then you had 17 patients of these 31 that progressed. So in this group, the validation cohort, which again was used to compare as the baseline, as in this is like the standard group as to see if the model was useful or not. did not show any difference between the proposed and classical model, right? We have the classical model of the diameter itself and the volume parameters and the functional, the fluid dynamics and all of that. This is, the proposed model. So there was no difference in this group. Then you had the small aneurysm cohort, which is a very interesting thing to note that among these 52 patients, as I mentioned, the AUC, the area under the receiving operating characteristic curve, was statistically better than the maximal diameter. So, going into the discussion a bit, we can first, of course, see here that this has an image correlation. Here, the curve for the model that they're proposing, shown by the blue circles here. This is the model that's using the volume characteristics that they drew from these CT scans. When you compare it with the maximal diameter alone, you have a greater area. So this is basically showing that you're having a better diagnostic value. Okay, so now the discussion itself. We then have the interesting fact here as a context is that you have an increased detection rate of small aneurysms. This is due to population-wide screening programs, so we're ever discovering smaller aneurysms. This has resulted in developing different prognostic tools to assess the progression risk of aneurysms. So in this study, we have a significant correlation between greater lumen volume and lower shear stress. So this is in relationship with aneurysms and their growth 1 year. Once again, we have better AUC and prognostic characteristics than the maximal diameter for the aneurysms, smaller than 5 centimeters in maximal diameter. So this is interesting because when we're looking at the aneurysms that are smaller than 5 centimeters in maximal diameter or 50 millimeters, then here if you compare the AUC, it's 0.79 versus 0.53. So what they're saying is that this is suggesting that this model may be useful for the measuring earlier stage aneurysms. Also, they mentioned some other conclusions that they drew was that when you have a low wall shear stress, this stress that is exerted in parallel sense to the wall, endovascular wall, we have a low stress, then this seems to be correlated with a greater risk for growth and rupture. So basically, just imagine when you have a higher stress, it seems that has a protective role for the growth. You would kind of tend to think that a higher stress would cause higher growth, but it's the other way around. So basically, what their reasoning is that you have the blood flow induced mechanical degradation of intraluminal thrombus. The thrombus that's on the wall is degraded by mechanical forces where the stress is higher. So a higher stress would be more protective, just to kind of conclude that thought. So then also, of course, they conclude that the strength of this model is combining morphologic and functional parameters with some other antagonistic actions. You have a greater lumen volume. This is a prothrombotic factor. So if you have a greater surface of interaction between blood and pathologic aortic wall, then this would end up being, as they say, a prothrombotic factor, the greater lumen volume. And also increasing the shear stress, the wall shear stress. This would be anti-thrombotic factor because of the mechanical action as I've just explained. So just connecting here a bit of the physics that we explained in the beginning with the statistical outcomes of the article. If we combine these different statistics, we can remember a bit of the concept of the parallel forces that we have on a surface that is per definition the shear stress that we were mentioning in the beginning. Remember the bars and the sheep, and the wool and the shearing of the sheep. Well, you have here an image that is showing saccular in the top row, saccular, and then on the bottom row, fusiform abdominal aortic aneurysms. The noteworthy fact is that you have the progression group on the left side with its two different morphological types, where you have a low wall shear stress showed by the cold colors. Then you have the stable growth group on the right side with a high wall shear stress. uh, you can see there that colors tend to be hotter, closer to the red spectrum, so that would note the higher wall shear stress there. So this is regardless of the morphological structure of the abdominal aortic aneurysms. The physical principles are clearly reflected, and the statistics they are coherent with the theory that um, is really being proven, that when you have a lower shear stress on the surface of the abdominal aortic aneurysm, you have a risk of higher rate of progression. Also, they conclude again that the abdominal aneurysms smaller than 50 millimeters in diameter. For this subgroup, the model has a high AUC value versus the maximal diameter, as in it's better as a model in this case. For these few patients, of course, which is a limitation among others. So, concluding, the high wall shear stress within the aneurysm is a protective factor regarding the growth rate, right? High stress of this type that I've explained is a protective factor because of the mechanical degradation of the thrombus itself. Also, we have that the increased lumen volume is correlated with an aneurysmal volumetric growth. So, of course, the volume, if it's greater, the growth will be also correlated with that. So the model itself integrates these two antagonistic factors. With better prognostic values to assess abdominal aneurysms and their progression risk than the maximal diameter alone. This is especially true for aneurysms that are smaller than 50 millimeters in diameter. So this is an article that you can read up on, and it was very interesting, I thought, that they're challenging a very classic concept of the diameter that's used a lot to assess the risk of rupture in abdominal aneurysms. And also, yeah, they also use classically the increase in this diameter over time. But here they're broadening the concept to include volumetrical and also dynamic fluid characteristics of the the abdominal aneurysms, and how this can help us understand the risk of rupture in aneurysms that are smaller than the usual threshold. So thank you very much for paying attention, and I hope this was useful to you as it was for me, and well, have a good evening.